time, and you're in the United States. So it's 6 o'clock over here in the evening. So we have a time reference of 6 hours. What I'm going to tell you is the impact of age of onset on the long-term course of bipolar disorder. And I will show many pictures, but also scientific data. And they may not be self-evident, but I will summarize the meaning of it after every portion. So if you have questions, please don't be shy to ask. Let's see if it works. Yes, I have no disclosures to make for this presentation. What we're going to talk about is bipolar disorder more in general, and then the issue of age of onset, which is kind of more complex than you might think. Then some findings of the Stanley Bipolar Network research of the last 25 years, and also the results of a recent meta-analysis by other researchers. And then I want to tell you something about the latest insight in staging models of bipolar disorder, because they relate to age of onset. And then finally, we come to some conclusions. So this is bipolar disorder, the very simple version. There's mania, often followed by depression, and then there is a symptom-free interval, which may take months or even years. And then in most people, if you don't treat, but also if you treat, there is the risk of recurrence of mania and depression. So that we call a manic depressive cycle. And these are the, maybe everyone can mute themselves so we don't have noise in between. These are the prototypes, which are defined in the current classification system of DSM-5, bipolar 1, which has manias and depression, bipolar 2 disorder, which has depression, but only hypomanias. And then you have what you can call bipolar light, which is in fact, we call that cyclothymia. Now, in this Stanley Network research project, we had the unique opportunity to follow people day by day. People recorded their moods every day for a year, or maybe everyone can mute because I hear much noise in the background. So please put off your microphone to mute. So we could follow people for a year, or sometimes 3 or 4 years, and we had daily ratings of mood, which gave a very fine-grained picture of the course of bipolar disorder. And I will show you some examples. These are quite classic examples of patients with bipolar 1 disorder and a woman with bipolar 2. You see the course of illness over 1 year. With episodes and intervals in between. And of course, there are also people who have a more complex form of bipolar disorder. We call that rapid cycling, a mixed episode. You see here 3 patients with rapid cycling bipolar disorder over the course of 1 year. And if you look even over 5 years with daily ratings, you see patients who have a very favorable course, like patient 1 and 2, and patients who have a not so favorable course, like patient 3, who had many depressions and sometimes mania, and patient 4, who had a continuous cycling pattern. And this was despite we tried to treat him with all kinds of psychotherapy and medication, but that did not result in a more favorable course. So if you think about age of onset in bipolar disorder, which mostly start with depression, it's quite complicated, because if somebody has his first depression, he's diagnosed with major depressive disorder, and sometimes even many years later, with the first mania or hypomania, you can diagnose this as bipolar disorder. And then in retrospect, in fact, mood disorder, which would then be called bipolar disorder, began with this first depression. So this was from the research of Manon Hullegas in Rotterdam in the Netherlands, and she followed children at risk. They were children of one or two parents with bipolar disorder, and they were followed for more than 10 years. And then they saw that of the children who got in the end, who also had bipolar disorder, which is the upper line in this graphic, you see that most of these children had previously depressive disorder or anxiety disorder. You can follow the lines here. You see that if you end up with bipolar disorder, which is the upper line, it's mostly preceded by another disorder, mostly a depression or an anxiety disorder, which means that age of onset in retrospect is often much more earlier than the first manic episode. So this is from the textbook of Goodwin and Jameson, and they compiled all the studies of bipolar disorder at that time, and they saw that the age of onset which is most prevalent is between, let's say, 15 and 25. This is the adolescence and early adulthood is the time that most patients get their first episode. Some are younger. There's much discussion about whether prepubertal children also can have bipolar disorder. And some patients are older, which are on the right side of this graphic. But most patients get their first episode between 15 and 25 years. So there are patients who have a early onset, which is typically, well, around 20 years, and patients who have a late onset bipolar disorder, meaning that they didn't have their first mood episode until, let's say, 50 or 60 years old. And the borderline between those early and late onset is rather arbitrary and was defined by these researchers as 50 years. So below 50, you call it early onset. And if you have your first manic or depressive episode after 50, you call that late onset bipolar disorder. Bellivier from France, he gave some more nuance, and he said, well, in the what we call early onset, you also have differences, and there are groups. He called it early onset, which was the mean of 17 years, and then intermediate onset in young adulthood in the mean onset of 27 years, and he called late onset everyone who was older than 45. So there's some discussion what is early onset and what is late onset, and of course there is not a sharp border between the two. So this is some general remarks about age of onset. Are there questions about that? If not,
I have a quick question, if you don't mind.
Yes,
I do notice that there's more and more young children being diagnosed as well that are not included in this.
Yes, well, there is much discussion about whether these young children actually have bipolar disorder, or that the criteria for what is called mania were so wide that many more children than who later had a classic bipolar disorder were included. And that is why the criteria for the newest classification DSM-5 were changed. So they were less inclusive for these young children, because in the last 25 years, there was a sort of 40-fold increase in the prevalence of bipolar disorder in young children. And everyone thought, well, this is not possible. There must be some artifact, and had to do with how loose you make the criteria for mania. Since children do have, of course, all kind of impulsivity and maybe some aberrant behavior, which you might call mania. But in the end, if you follow them up, they don't have a real bipolar disorder. So that is why this discussion has tamed a little bit, and less children are diagnosed with bipolar disorder now following the latest criteria. Is that an answer to your question?
Yes, thank you.
Okay, so let's look what the Stanley data told us. This is about more than 500 people. And what you see here on the right side is what I already showed, was the compilation of Goodwin and Jameson. And you see that the histogram, as we call it, that means the number of people who have a age of onset at a certain age. You see on the the y-axis, the horizontal axis, you see the age, and on the vertical axis, you see the number of patients who had retrospectively an age of onset. And you see here that there's a peak around 20 years. And these people, when they entered the study, already had a mean age of 42, which means that, on average, their bipolar disorder started 20 years before. And their mean age of onset was 23. So it's much in line with what is from other studies, which is important. If you do a study and you find that your patients are very different from what has already been reported, then you have to ask whether the findings of your study are generalizability, can be applicable to other patients. So as you see, the graphic on the left side from the Stanley Network and the graphic on the right side from the compilation of Goodwin and Jameson are quite close to each other, which is reassuring for the generalizability of our findings. What we also saw is that, as I already said, most patients started their mood disorder with a depression. What you see here is what we call a scatter plot. So every dot is a patient or two patients who had the same data. And what you see above the diagonal line are the patients who had first a depression and later a mania or hypomania, and below the line there are the patients which are fewer who had a hypomania first or a mania first. You see here only 15% started their bipolar disorder in retrospect with mania or hypomania. So they were first diagnosed with depression, which is common. If you look, this was retrospectively recorded. If you look prospectively, then a large majority of patients start with depressive features and only a second become manic or hypomanic. Now, we will look now at some determinants of early onset. And one of the determinants which we hypothesized was if you have a genetic vulnerability for bipolar disorder, then it is probable that your mood disorder starts earlier than if you have not a genetic loading. And that you see here, here you see how many of the patients had a positive family for bipolar disorder in the red, and for depression also in the red. Sorry, red is bipolar disorder and blue is depression. And you see here those with an early age of onset before 20 had much more parents. There were much more patients who had a parent with bipolar disorder than the patients who had a later age of onset. You see here that the red line is decreasing with a later age of onset, which means that genetic loading probably makes that your mood disorder manifest on an earlier age. Now, the second risk factor was whether people had an early abuse, had a history of physical or sexual or verbal abuse. And we hypothesized that this would be a risk factor for early onset, because if you have been abused in many psychiatric disorder, also in psychotic disorder, depression, and anxiety disorder, you see that the disorder has a more severe course and an earlier onset. And we found indeed that if you see the graphic on the left side, which are the prevalence of physical abuse, and on the right side, sexual abuse, which were combined with this like a complex picture. But you see here, those who had a family history of bipolar for mood disorder, in combination with a history of physical or sexual abuse. And what you see here, if we go from left to right, first the physical abuse, the lower line in the graphic, which means the earlier age of onset, these were patients who had a family history of mood disorder, as well as a personal history of physical abuse. And then next to them are those with physical abuse with no family history of bipolar disorder or mood disorder, and right of them are those with no physical abuse with a history of mood disorder in the family, and then the highest age of onset, 24, were those patients who neither had a history of physical abuse or a positive family history of mood disorder. And the same was true for sexual abuse, which means that if you have these two risk factors, early abuse and a family history of mood disorder, combined, then you have that is the risk factor for the most early age of onset. So these combined risk factors make that if you have vulnerability for bipolar disorder, it will present at an earlier age, which of course, as you can imagine, the younger you are when you have a psychiatric disorder, the more impact it has on your further development. So it is very unfavorable to have an early onset. If you have an onset when you're 50, then you already had a large part of your life, the possibility to develop yourself, to have a job, to have a family, and so on. So this is less unfavorable than an early onset. So this shows from our data that having a history of abuse in combination with the family history of mood disorder makes that your mood disorder manifests itself at an earlier age with all the consequences of that. What we also saw is that if you have an early age of onset, then the delay between the first symptoms and the first treatment is longer than if you have a later age of onset, which somehow is self-evident because symptoms which manifest at an earlier age may be confused for well, the phenomena which you see in adolescents, also in normal young people. So this makes doctors hesitant to make a diagnosis, which means it takes longer and maybe more episodes or more severe symptoms to make a diagnosis of bipolar disorder and to start a treatment. Now, I will show you some graphics which are a little bit complicated, but what you see in these following graphics are 4 groups of our patients. Those who had a childhood onset, meaning earlier than 13 years of age. Those who had an adolescent onset between 13 and 18 years, early adulthood onset 19 to 29, and a late adulthood onset beyond 30 years. And what you see here, the higher the line is in the graphic, the more severe is the depression and mania, and the highest line belongs to sorry, I see a question. I will answer that as soon as possible. The highest line belongs to the early onset. The question was from Nadia that the data are already, well, these data in fact are 20 years old. Would it make any difference if you show newer data? I'm not aware of newer data. I will share with you some of the data of a meta-analysis, but most research is already quite old. And if you overlook that, these data do not change a lot with the time. These data are quite, I think if you would repeat the research now, you would probably find the same. So in the same way, you can see that those patients who had a childhood onset this is prospectively research. So this was while they were in the study. So that means many years after they had the first mania or depression, they entered the Stanley study and they were followed for 4 years, day by day. And then you saw that those with the early onset, again in the highest line, had in those 4 years most days depressed. They had more days depressed than those people who had a late onset bipolar disorder. And the same was true, although in a lesser extent, for the number of days manic in 1 year, which means if you combine it with the previous graphics, that if you have an early age of onset, the risk that you have more days depressed and more severe depression is higher than if you have a later age of onset. And the same was true for days of ultradian cycling, meaning that in one day you can experience mania and depression at the same day. So it mixes within a day. And then in the last graphic, you see that the day euthymic, meaning that you don't have mood symptoms, was lowest in those with a childhood onset. So if you look at the prospective course of illness, then those people with a early onset had the most unfavorable course over the later years of their illness. Despite being treated, all these people received adequate treatment. And the same is true for the number of mood episodes per year during these 4 years of follow-up. We also looked at rapid cycling, and then the same pattern you see there, that those people who had a rapid cycling course of illness while being in this project, so for many people, many years after their first onset of illness, then you see, looking back, those people who had now a rapid cycling course in the blue, this is the blue bar, they had an earlier age that they had their first mania, first depression, or a first mood symptoms, meaning that early age of onset is associated with a later rapid cycling course. If you looked in these patients,
okay, I'm doing a presentation.
Can you turn off your sound?
Sorry.
okay. People were asked whether they had ever had a serious suicide attempt while having their mood disorder. And then what we found is that those who had a history of serious suicide attempt, they had a younger age of onset than those who had not. So again, a younger age of onset was associated with a higher risk of having made a suicide attempt after onset of illness. So if I summarize what we found in relationship to early age of onset, that having a parental history of bipolar disorders, meaning having a genetic risk for bipolar disorder, is related to an early age of onset, and also having a history of abuse. And these two combined made the earliest age of onset in this sample. Second, if you look at the course of illness, then those who had an early age of onset had a longer delay to their first treatment. They had more mood episodes per year, sometimes in the rapid cycling pattern. They had more manic and depressive days per year of follow-up. If they were depressed or manic, they had a higher severity of mood symptoms, and they had a history of more serious suicide attempts. Meaning, if you take this together, if you have risk factors for bipolar disorder from your family or from your early development, then you have an earlier age of onset, but also you have a more unfavorable course of later illness. Let's see if there are some comments. Look to that. Okay. These are questions which are not related to what I have told until now. I will try to answer them later. And some personal experiences. This was from the Stanley study, which started, as I already said, in 1995, and we followed patients until 2000 and 2003, and we are still analyzing these data and publishing papers because there was such a rich data set, especially since we have followed these people day by day with their life charts. Now, this is a meta-analysis, and a meta-analysis is of value because then the results of several studies are combined, and then you can see whether what one study finds is repeated by other studies. So this was published in 2015 and was called "Is Age of Onset Associated with Severity, Prognosis and Clinical Features in Bipolar Disorder?" So these are in fact the same issues as I have told you about what we investigated in the Stanley Network. And then these researchers, they pooled the data of several studies, and they looked at histories of suicide attempt, and they found that indeed, if you combine these, what you see here are these squares and these parallelograms, meaning if you are on the right side of the line with the one, that means that the studies who investigated whether people with bipolar disorder in relationship to controls who did not have bipolar disorder had a more history of suicide attempts. And indeed, all these studies found that patients with bipolar disorder had more often a history of suicide attempt. And then they looked at the history of substance abuse. And you see here, this is the study from the Stanley Network, leveraged et al. And here also. And if it was combined with other studies, then you see that there is a signal that, although not very, what you see here is a parallelogram which touches the line of the one, meaning that the overall result is that people with bipolar disorder have probably a larger risk for being also addicted to alcohol, but it was not really statistical significant because it touches this line. But there was, and you can see some studies do, but other large studies, some did not find this association. In fact, the study by Leverage, which was part of the Stanley Network, what we found a positive signal, but it was, as you see here, it crosses this line, meaning that what we found was not statistically significant. Well, the same was true for substance abuse, which you see here, and then you have a more significant finding because this figure does not touch this line, meaning that all the results from these studies indicate that if you have bipolar disorder, you have a much larger chance to have also a substance abuse disorder, drug abuse. They looked at comorbidity of anxiety disorder and found that there was, looking overall in this study, this again is a study from the Stanley Network, leverage et al. That people who have a diagnosis of bipolar disorder have a larger risk of having also an anxiety disorder. They looked at the severity of depressions and compared with people with unipolar depression, I think. But with controls, and they looked here. I didn't say it really. They compared here the people with early and late onset. So what you see here, people with early onset have a higher severity of depression than the people with a late onset. So I must correct myself. I didn't explain it well. But what we have seen in the previous slides is that you see here, these are the people with early onset, and this is with late onset. So this favors that people with early onset have have more often a history of suicide attempts, have more often a alcohol and substance abuse, and people with early onset have more often a comorbid anxiety disorder, and also have more often a higher severity of depression. This is in line with what we found in the Stanley study. What they did find, to put it together, if you have an early age of onset from this meta-analysis of studies, so a combination of various research projects, there are more suicide attempts, there is a more higher risk of alcohol abuse, substance abuse, there's a higher prevalence of anxiety disorder, and if people are depressed, their depression is more severe than if you have a later onset. What they did not find from this meta-analysis was that severity of mania is associated with early age of onset, having psychotic features while being in a mania or depression, having mixed episodes or rapid cycling. This was not in this meta-analysis associated with early age of onset. So, does this give rise to questions?
I don't think necessary questions, but lots of commentary that maybe we can save toward the end, because I bet there's many of us that have things to add to this or to question with this.
Okay.
If
So
that's fair.
Yeah, okay, that's fine. That's fine. So staging. Staging means that if a disorder is progressive, then you can make difference between early stages of illness and later stages. The most well-known example is cancer. There are early stages of cancer which are only very well-defined tumors, and late stages which are tumors who had metastasis over the whole body. And of course, as you can imagine, an early stage of illness is much more accessible for treatment than a later stage of illness. And this is true in oncology, so cancer medicine. This is true in cardiovascular medicine, in rheumatology, and many other chronic diseases that if you look over the development of an illness, many illnesses, chronic illnesses, develop to a stage which is harder to treat if you wait longer with treatment. And in psychiatry, this is more difficult to define because we don't really know the etiology and the mechanisms of psychiatric disorders so well as we know them of rheuma and cancer and cardiovascular disease. So there have been developments in psychiatry to develop models for staging, which are a little bit hypothetical, but under development. And in fact, there are 3 different sort of models. What you see here. One is published by Michael Burke from Australia, and he looked at the rate of recurrence of mood episodes. I will come to that later. The second model was developed by Kapczynski from Brazil, and he looked at the level of functioning in between episodes. And he hypothesized that if a bipolar disorder develops itself to more severe stages, the level of functioning of people in between episodes becomes less. So people are less able to function in their daily life in between those mood episodes if they have an advanced stage of illness. And the third model was published by Anne Duffy from Canada, and she focused more on the early stages, and she saw that there are young people who develop towards a bipolar disorder, what she called a classic bipolar disorder with euphoric manias, depressions, which is highly sensitive for treatment with lithium, while other patients develop in a more what we call a psychotic form of bipolar disorder or schizoaffective disorder, which is less responding to lithium. So these are 3 models. I will focus on the model by Burke et al. Because our data in the Stanley network allowed us to look at this episode pattern, because we have recorded retrospectively and prospectively a very fine-grained picture of mood disorders of these individual patients. Now, I already showed you this slide from another project from the Netherlands, which showed that if you are vulnerable for bipolar disorder because you have one or two parents also having bipolar disorder, and you will develop over the years a bipolar mood disorder, then it is in most cases preceded by depression or anxiety before you get your first hypomania or mania. Now, this is also, you can see this in this is a model by Michael Burke. And he says, well, you have various stages of having bipolar disorder. Stage 0 means that you have a genetic risk, meaning that your parents or your siblings have a diagnosis of bipolar disorder. You may not have any symptoms, but you are at the higher risks than in the general population to develop bipolar disorder. And then you can develop psychiatric symptoms without having a psychiatric disorder. So anxiety symptoms, sleep disorders, or mild depressive complaints, but not a real psychiatric or mood disorder. He calls this stage 1. The question is, what do I mean by genetic risk? This is here defined as having a first-degree relative who was diagnosed with bipolar disorder. So your parents or your brothers and sisters or your own children having a bipolar disorder without having it yourself, then you are at risk for developing bipolar disorder. So then there is stage 1, which means there are slight psychiatric symptoms, but not a disorder. And then you have what we call the age of onset, as I already discussed with you. And then this may be a depression or it may be a mania. This is called, in this model, is stage 2. And if you have a recurrence, mania or depression, then you call that stage 3 in this model, and stage 4 means that you have symptoms all the time. I showed you 2 of these patients in my earlier graph, that there are patients who do not have these inter-episodic remissions. They have, in fact, symptoms all the time. We call this stage 4. Now, there is a problem if your mood disorder starts with a depression, because then you cannot diagnose bipolar disorder, and you may be at risk for bipolar disorder, and you have a first depression, but then you cannot say this is a first episode of bipolar disorder. It might be, but it only will show if you have a mania afterwards. So this is a problem in this staging model with defining age of onset. Now, one of my PhD students, Ava van der Markt, she looked back at these Stanley data from. Sorry, can you mute your microphone, please?
Come on. Please turn off your microphone.
You can mute Matt, Catherine, the host.
Yes, I was going to say that as the host, you can mute everybody. You will have the power to mute everybody. That's
what I would suggest.
Yeah.
Okay, thank you.
I hope I will not be muted. No, okay, thank you. So Ava van der Markt, she looked back in this data and she looked at if we try to apply such a staging model on this data that we have from the Stanley database, what do we found? Now, we had 98 people from the Netherlands who we had what we call a retrospective life chart, meaning that at the entry of the study, we had very accurately reconstructed the earlier illness course from the age of onset until entry of the study. And then we saw what we already saw in the total sample, that 2/3 of the patients started with depression and only a minority started with mania, as in the whole sample. We look back retrospectively here and prospective, and then I will show you some examples of these retrospective illness courses. So this was a female born in 1967. So at the study entry, she was about 30. And her mood disorder started at age 20 with the depression you see here, 1988. And then 2 years later, she had her first mania, age 23. And then she had some recurrences afterwards. This man, he was born in 1949. He had a first, his bipolar disorder started with mania, so it was more the exception than the rule. He had a mania at age 26, and then a recurrence about 12 years later. And you see, he mostly had manias, and only here, very immediately before starting the Stanley study, he had also depressive complaints. And then this patient, female born in 1947, she started her bipolar disorder with a cycling course over 1 year. You see here, she had depressive symptoms, then mania, then depression again, mania here, and then depression. And then several years without any significant symptoms, only minor depressive symptoms. So you see here that people with bipolar I disorder can have quite a different course of illness if you look back. We found that in this sample of 98 patients, 18% had started with a mania, 12% started with a mania immediately followed by depression as a first episode, 24% had the opposite, a depression immediately followed by a mania, 40% had a depression first and then after sometimes only after years had a first mania, and only a very small minority had a first hypomania, which was followed many years later by a first clinical depression. When we looked, when we reconstructed the course of illness after age of onset for the first 5 years, then we saw here, this is a little bit complicated, but what you see here is the number of patients who started here with a first episode, which is called stage 2 in the model. And then you see here the number of patients declines here, and then they enter in stage 3, meaning having a recurrence. And some patients even enter in a chronic stage, meaning that they had 2 years of continuous symptoms, and some of these then afterwards came into a stage which was stage 3 again, so having a recurrent course of illness. What you see here is that most patients, after they have their first episode, will go to a recurrence. It's here. So, to come to some conclusions, bipolar disorder is a heterogeneous condition that arises from the additive and interactive effects of multiple genetic and environmental risk factors at different points of development. Age of onset is not consistently defined across the studies. Some speak about early age of onset, some about late. Some will think age of onset is the first mania. Others say it's the first depression. So it's a little bit inconsistently defined. It is unclear whether childhood onset bipolar disorder, adolescent or adult onset bipolar disorder, and late life, late onset bipolar disorder have distinct etiological and pathogenetic backgrounds. There are some differences in the presentation, but we do not know deep in the mechanism if it is a different sort of bipolar disorder. Genetic factors and childhood adversities are associated with an earlier age of onset of bipolar disorder. Evidence of a negative impact of early age of onset on the longitudinal course of bipolar disorder is inconsistent, meaning that there is quite a general assumption that early onset is associated with a more unfavorable course of bipolar disorder, but the different aspects of bipolar disorder are not consistent among the studies. And finally, prospective staging bipolar disorder is complicated by the high prevalence of depressions preceding first mania. So you don't know if somebody who is at risk for bipolar disorder and has a first depression, whether it will stay a depressive disorder or whether it will develop into a first manic illness. So at the end, I want to thank my friends and my colleagues from the former Stanley Network. You see them here. Bob Post, who has founded the network, myself, my colleague Willem Nolan, Tricia Soupis, Mark Fry, the late Laurie Elschuler, Paul Keck, Sue McElroy, Kirk Denikoff, and Gabriel Leverage. And not on the slide is Heinz Kunze from Germany. And I also want to thank my current collaborators in the Netherlands. I won't call their names, there are many, but the message here is, if you do research, you can never do that by yourself. You always need a large network of researchers, and also many, many patients who participate in research to know more about the characteristics of bipolar disorder. So I'd like to thank you for your attention and see whether there is some questions. Catherine, could you moderate this, the questions?
Yes. So does anyone have a question they'd like to ask first?
Yes, I have a question.
Go ahead.
Hi, thank you, Dr. Kupka. I hope I'm saying your name correctly.
Absolutely. Yes.
Thank you. Yeah, I had a few questions generally about the treatment process typically used. But you know, my husband has bipolar, and the journey has just been so experimental. It's sort of like, hey, try these combinations of medication. It's so trial and error, and I'm wondering, why isn't there a more advanced approach for, you know, figuring out medication and not bringing patients on this, you know, just a random journey.
Yeah, that's a very good question. I don't know if it's random. It is by what we call bipolar disorder is in fact a quite heterogeneous condition, as you can see from all these results, which are not very consistent. Meaning that what looks like bipolar disorder more may be caused by different mechanisms, and these have a different response to treatment. So we know from large studies that some medications work and some do not work. As you know, lithium is a medication that works in many patients, but not in all patients. And the unfortunate part is that we don't have biomarkers to tell which patients will respond to a particular medicine, meaning that you start treating somebody with manic symptoms or depressive symptoms with a medication of which we assume or which we know that it will work in large groups of people, but we are not certain that it will work in this individual case. And there are some algorithms to follow, what you take first, and then if it doesn't work, you take second, and so on. And in some people, you are immediately on the right medication, and in other people, it takes quite some trials to find a medication that works, or even a combination that works. And this is very frustrating for the patient, for the family, and also for the doctor, that you cannot find biomarkers that will indicate which medication will work in your case. Is that a sufficient answer for your question?
Yes, that's helpful. Thank you.
Well, what I want to add is that a doctor has, of course, some rationale to choose. So there are some clinical profiles that you might say, well, the patient with this clinical profile may respond probably to lithium, or may respond probably to Depakote or to olanzapine and so on. But it's always a guess. You never know for sure. So you have to try, You have to record the response, and if it works, you go on. If it doesn't work, you stop. You try something else, and this is sometimes quite time-consuming, yes, and therefore frustrating.
And just a brief follow-up, whatever is prescribed, is it supposed to be taken exactly as prescribed, or could the patient tweak it a little bit on their own?
Preferably not. What I would always say, we start with an average dose, and then we find which is the lowest dose for you. And we do that very carefully. So if somebody responds to a medication, you leave that for a while. If there are no side effects, you can, well, if it's well tolerated, you can leave it like that. And if there are side effects, you lower the dose very slowly to see whether there is a dose which helps somebody without having much trouble.
Okay, all right, thank you. I'll let others go and I'll come back around later.
Does anyone have another question?
I do.
Yeah.
Go ahead.
Well, I guess in listening to your research here, some things that came to my mind, words that you had said was, that these were there was adequate treatment involved, and maybe it depends on where you live. So I haven't been on this journey as a caregiver for a while, but the past couple of years, from what I gather, our story is not very different from others. It also, it has to have a massive impact on your data that here in the United States, people are diagnosed many, many years later. And I think that's also common in other places around the world. And often it's with the introduction of antidepressants, SSRIs or SSNIs. And then also for another challenge is that usually it's an acute episode that has them inpatient where you are giving a tremendous amount of medication, a massive cocktail, which can cause even more instability and more challenges. And so adequate treatment is very, very challenging to get here in the States because it's not an individual illness or disorder or whatever you want to call it. You have to have a support network in place and learn insight in food and your circadian rhythm. There's a whole other of course medication, but you want to minimize that because so much of that is creates the instability. So in my learning with people with lived experience, so many can pinpoint back to their childhood. They didn't know what mania looked like. They didn't understand that mania can be irritability. So they may think that the first manic episode was when they went absolutely acute into a full-blown manic episode. So I guess there's a lot of questions that I have in there that are just, I don't know if that makes sense to you.
Well, it's always different if you look back. Then you see you have a different interpretation of early experiences than if you look forward. There are many people who have mania-like experiences who never develop bipolar disorder, but they do not enter in our research. So if I tell you about what we found, then it's a selection of people who had bipolar disorder in the end. But many people who have the same things at an earlier stage, they do not develop bipolar disorder, so we didn't see that. That's always a thing in research that you always have to ask which people are being investigated. This is not the whole population with bipolar disorder. It's only those people who were motivated to take part in our research and who had a very well-established bipolar disorder. So your experience in a broader field may be quite different because there's a different kind of people. There's always the caveat in research that you look at a selection of people.
Thank you. I appreciate that. And I do. And I come from a lens of adequate treatment. It's very rare that somebody comes off right away diagnosed with bipolar and has adequate treatment. So I appreciate the clarification.
Yeah.
Next question.
Yes,
Huh?
I have a question. So my question is that I have a daughter who's 14 and we're in the middle of not sleeping, and anyway, what the question though is, I've read about ultradian rapid cycling. Definitely we can go, I mean, she's 14, right? But we can go from being elated, jumping around, smiling, dancing, singing to me in my bedroom, and then an hour later she's crying and doesn't want to live. So I'm looking at this in the context of rapid cycling, which I would say we're experiencing, but I also kind of seem to mix it up with a mixed episode. So can you just define for me the difference?
Well, in fact, there is not a real difference. A mixed episode means that you have, in a very short time, you have a mixture between depressive and manic symptoms, or even at the same time, that you feel overactivated and sad at the same time, or you feel happy and you feel slowed down. This is a mix of depressive and manic symptoms. Rapid cycling means that they alternate. So you have depression, full-blown depression, and then 2 weeks later, you have a full-blown mania, hypomania. And if it comes very close to each other, you call it ultradian cycle, meaning in the morning, people are depressed. In the evening, they're hypomanic. Next morning, they're depressed, and so on. And if you have a mixed episode, then it's all over the place. Then you have a mixture of overactivation and sadness, or inhibition and joy, which is very confusing. This was already found long before there were medications. So more than 100 years ago, Emil Kraepelin described these mixtures of moods in his patients. But it can be very confusing to look at. So your daughter, was she diagnosed with bipolar disorder already?
Yes, bipolar 1.
Okay. Now, I think in young people, these mixtures and cycling are much more prevalent than in older and adults, because adolescent brains are much less developed than adult brains. And even in healthy adolescents, you see this mix of emotions. So that's then you come to a normal aspect of development and a aspect of bipolar disorder mingling with each other.
Yeah, I will say my older son, who's now 23, he was diagnosed at 16 with bipolar 1 with psychotic features, and definitely his cycling seems to have stretched out. It's not as rapid or fast as it was when he was younger. So I can see that in my older son too.
Okay.
Thank you.
Lori?
Hi, yes. Thanks, doctor. First of all, it's more of an observation / question. I understand about the early onset being an indicator of a possibly worse manifestation of the disorder over time. But since there's a not insignificant number of people who don't get diagnosed because they present with depression. Mm-hmm. And I'm speaking in particular about what currently is called bipolar 2. So mm-hmm. It's not full-blown mania. And they don't talk about those hypomanias because they don't think of them as there's anything wrong. Mm-hmm. So over the course of time, they're getting underdiagnosed, undertreated, sometimes adversely treated if it turns out that in fact they really do have bipolar disorder 2 and they've been being treated with antidepressants. Would you say that there's a correlation then between what you have determined to be early onsets, yes, severity, and then someone at the same time who didn't get diagnosed early enough?
Yes. Well, bipolar 2 is quite a complex issue because people, as you say, they come with depression and they don't mention their hypomanias because they think, well, that's quite well. I'm energetic. I feel well. And so if somebody presents with repeated depressions, which started at an early age and was in the context of a family, so parents who had also a mood disorder, then you have to look for past hypomanias because these are such a profile makes you suspect for latent bipolar disorder. And of course, and sometimes you find it, and you have to ask not only the patient himself but also a spouse or somebody else who knows them very well. And then you look for episodes of heightened energy and activity which are not typical for this person. And if you find that in combination with depression, you call that bipolar 2, which may change the way you treat the depression. So it's quite you have to do some investigation in the past if somebody presents with repeated depressions and having a family history of bipolar disorder. It's a very important issue you raise here.
What if they don't have a family history of bipolar
Yeah.
disorder?
Yeah, then you have only one thing is that you have to, if you don't find hypomania in the past, then it's depression. So you must not diagnose something which is not there. But if somebody presents with an early onset repeated depression, we always look for past hypomanias. Well, and
Right.
of course,
No, yes,
if you don't find them, it's a depressive disorder.
Right. No, yes, I completely agree with that. My stance more was, if in fact it turns out that in looking back, you understand that in fact you did have hypomanic episodes.
Mm-hmm.
You just didn't realize it because you
Mm-hmm.
didn't know that there was such a thing,
Yeah.
and you thought you were fine, and years and years and years go by. My understanding is that the severity of the disorder can be pretty bad.
That's true.
Yeah, that was what my stance was, because I know that you've outlined very clearly that early onset, but I'm just drawing the correlation between, well, there's early onset, and then you may very well have been early onset, but you didn't get diagnosed correct.
Yes, that's true. And of course, it may be that you had not so clear symptoms, that the diagnosis was not made, or you were diagnosed with somebody's diagnosed with repeated depressions, and the treatment didn't work
MDD.
because it was bipolar disorder. Yes.
Right.
But that is the problem in psychiatry. We don't have anything else than listening to people and looking at behavior. We don't have any tests, scans, blood tests, or you name it, to confirm diagnosis. It's all only about looking and listening to people.
I was just wondering, because I'm finishing up An Unquiet Mind right now, and it was published in '95, and at that time, which was probably even the early '90s, while she was getting ready to publish, the Genome Project was going on.
Yes.
How close are they? Do they still not have any sort of molecular?
What the genetic research in psychiatry reveals is that there are many signals in the genome for psychiatric illness, but they are so much that, and none of them is specific. So if you look at the group of people with bipolar disorder, compare them with unipolar depression, compare them with schizophrenia, there's an enormous overlap in genetic findings. And it's always about very many genes which do a little bit of the vulnerability of this disorder. So this you can say this is quite disappointing. There's no specific genes for any disease. It means that the etiology of psychiatric disorders is overlapping. And of course, we know that because there's much confusion between, as we now discuss, between depression and bipolar disorder on the one hand, but also between severe bipolar disorder and schizophrenia. There's also a sort of shaded borderland between the two, meaning that there are many variants in between. And this is also revealed with the genetic research. So this, you can say it's disappointing. You can also say, well, that's the truth in psychiatry. And there has been many findings in the last 30 years, but none of them is specific for any disorder.
Do you think that there's going to be any time in the next 20 years where they're going to have a blood test to determine?
No, I don't think so. In fact,
Yeah, wishful thinking.
Yes, well, we rely on stories, and well, that's the best we have.
Yes, thank you.
Kat?
Yes, thank you, Dr. Kupka. My question is, do you think that epigenetics could serve as an explanation for the large variation that we see in bipolar spectrum disorders?
Yes. Epigenetics is the environmental impact on genetic loading. Well, first of all, you have an enormous variety in genetics, as already discussed, and then you have enormous variety on environmental factors. So there is an impact since these two interact in the development of individuals that may explain why it is such a heterogeneous disorder with such a diverse course of illness. There are some people who just have a few episodes, while other people have numerous episodes within a few years. So probably there is an interaction between genetic factors and environmental factors, as you say. Yes.
Who had another question? Nadia? And I'm gonna-
Yes. Hello. Yes. This is Nadia, and I actually wrote my questions. So thank you so much, Dr. Kupka. First of all, and by the way, I met with Dr. Post. I'm in Bethesda, Maryland, and that's where
Okay.
I'm. So how do you define recovery? Number one question. Number two, have you seen people recover from bipolar? I believe there have been many cases which doctors are not aware of. Number three, among other tools, since you guys, medical community, recognizes the factor of emotional or physical abuse or some kind of non-genetic but behavioral dysregulation in the family while the person affected growing up. So have you recommended as a tool, as a treatment tool, to work on stopping relationship with those who abuse them with the children? I think that might be actually helpful.
Okay.
And also, in general, have you seen, I echo the first person who started, by the way, saying that by the time my son, for example, understands what's going on with him or trying to understand what's going on with him, he went through the medical psychiatric establishment and being thrown as darts, different medications. So now we're dealing with trying to clear his brain back to the baseline in addition to whatever he's suffering from. So that's kind of a note also to the medical system. But the most importantly, how do you define recovery?
Yes.
Have you seen people recover, and have you
Yeah.
recommended them to stop abusive relationship?
Recovery you can define in various ways. Symptomatic recovery, meaning you don't have mood symptoms anymore. You can have functional recovery, meaning that you can, when you have, well, with or without mood symptoms, you can function, you can do what you want to do as good as you can, functional recovery. Then you have societal recovery, which means that you can function in society, that you have a role in the family or in a job or anything. And then at last, we have what we call personal recovery, which means that you have integrated having this vulnerability for bipolar disorder in your life, that you can live with it. So this is a layer of various recoveries. And we hope that, of course, they are all linked together, that people can at least achieve symptomatic recovery, and then at least have the best functional recovery they can, and then have some role in society, and of course integrate that in their lives. That would be ideal, and many people get to a very significant point with that. You question whether I know people who have recovered. Yes, I know them, but that doesn't mean that they don't fall back. Many people recover after an episode. It may take a year, and then they have many years of functioning very well, and they may have a recurrence and then do the same process again. I also know people who did not have recurrences. That depends on how long they will meet me. And they will, of course, if somebody does very well, he doesn't come to my office anymore after 2 or 3 years. So we are doing a research project. In fact, the same person I showed, we are asking people who are well for more than 5 years without having any treatment, any medical treatment, and we try to find them, and it's not easy. About
No,
abuse.
because they don't want to do anything with the medical psychiatric establishment. And I
Well,
don't blame them.
Absolutely.
Yes,
And I don't
well,
blame them.
no,
And
well,
I think it's time for us to look into non-medical model of helping those people.
we
Because we
recruited-
all,
Uh,
doctor,
okay.
don't you agree that majority of people over the course of their life get into psychiatric kind of extreme state to some degree, something like what you would call psychosis,
no,
one way or another.
no, I don't think so. I think there are many people who can benefit from adequate psychological and medical treatment, and then that their recurrences are not so heavy than they were before. So I think people, if they are treated wisely, they can benefit from treatment. And there are also people who are not treated. We try to find them, and they do well. Of course, this is one of part that there is such a large collection of mood disorders that there are people who do well with treatment, without treatment, and people who do not well with or without treatment.
Thank you.
Thank you so much.
The question about abuse, it's very important. Of course, we cannot prevent. We can try to prevent abuse. What we do is that we always, in our patients in the Netherlands, we look at the families. So patients who have children, we try to see how are the children doing, because they are at risk already. And we try to prevent that in the family there is some sort of, well, maybe not abuse, but some dysfunctional relationships. And to prevent people at risk and having disorders. Yes. I don't know how much time do we have, Catherine? Because it's already.
I was just going to say thank you, and I think that's enough questions for you because you've taken on so many questions already. So thank you so much for your presentation.
It was an honor to do so for you. I always like to speak to people who are primarily involved with this terrible condition. I do it now for more than 25 years. I see many talented people having this disorder, suffering from it, and we try to do our best to help them as good as we can. And sometimes we are very successful, and sometimes absolutely not. And this is very disappointing for everybody. But it's also rewarding if you can do something for one of my patients. Okay.
Thank you. All right.
So I say goodbye. It's 7 o'clock here in Holland. I'm going to make dinner, and maybe we'll meet again.
Thank
Have
you
a
very
good-
much, doctor, for your
Bye-bye.
time.
Thank you, Dr. Kupka.
Bye bye.
Bye.